So at the recent Targeted Therapies in Lung Cancer meeting in Santa Monica in February of 2023, I was asked to speak on the topic of targeted therapies in consolidation, that is, after chemo and radiation for patients with unresectable stage 3, potentially curable non-small cell lung cancer. And I started with an older historical context that there was actually an older SWOG trial called SWOG0023 that Dr. Karen Kelly was the principal investigator for. It was published in JCO more than a decade ago. And that actually was the first that looked in a very systematic, prospective way at targeted therapy. This was with Gefitinib after not just chemo and radiation concurrently, but then consolidation docetaxel, which was our standard approach at the time based on a very promising phase II result that we essentially universally adopted. And then the randomization was to Gefitinib or placebo. And that was a humbling trial result because it showed that there was a significant difference, but it favored placebo, and that Gefitinib was associated with an inferior result, a median overall survival 12 months shorter. But this was in an unselected population. And this was, of course, at a time so long ago that it's almost hard to remember that we ever used targeted therapies in an untargeted way. But it's a totally different question when we apply this specifically to patients with a driver mutation. And the most relevant trial moving forward is one called LAURA that looks at osimertinib given to patients with an EGFR mutation who have received either concurrent or sequential chemoradiation. So a little broader eligibility than the concurrent chemoradiation that we would routinely use as the backbone heading into the Pacific trial with consolidation durvalumab. I would also note that in the LAURA trial, durvalumab is not given, and instead patients are randomized to placebo or osimertinib as the consolidation therapy, with progression-free survival as the primary endpoint, and the treatment continuing until progression, which means that it's essentially indefinite treatment. Now, crossover is allowed, but it's a big, and I would say different question when you're talking about giving therapy indefinitely compared to a time-limited course of treatment. These are patients who have a significant risk of relapse, probably at least 2/3 of patients relapsing. And I would also note that this question of the relative value of osimertinib in this molecularly selected EGFR mutation positive population is important, partly because of the relative value of the osimertinib, and also because this trial does not include durvalumab. And there's actually good reason for this. One is that we have some limited data looking at subsets from the Pacific trial, looking at other retrospective data outside of Pacific, that the patients with an EGFR mutation don't seem to benefit from durvalumab, and that we also know that patients who are on immunotherapy and then need to transition immediately to osimertinib because they have disease progression are at considerable risk for life-threatening or even fatal interstitial lung disease. And so that's a real reason to carve out these patients with an EGFR mutation separately and not just treat them exactly like the patients on Pacific because they were eligible, because they may get none of the benefit and some real risk associated with that. There's also the question of what to do for patients with other driver mutations, RET or ALK or ROS1, et cetera. Most of these patients don't seem to benefit in the advanced disease setting from immunotherapy and may well have some of the same toxicity challenges if needing to transition from immunotherapy over to targeted therapy, but we just don't know. We don't even have the results from the LAURA trial, although that has completed enrollment, 200 patients. We expect to see the data trickling in from this. We expect to see a presentation hopefully late 2023 or early 2024. I would say it's extremely likely that this trial will be positive for its progression for PFS endpoint. The question really is whether that is enough to consider this to be an extremely welcome, needed standard of care, or whether we should be holding out for an overall survival benefit if patients could do just as well crossing over to osimertinib. And of course, this leaves open the question of what to do for all the other patients with a different driver mutation that we don't have a trial result yet for.